I'm going to turn over to Josh Bonkowsky, who will speak on big data findings in ALD and new data directions. Thanks, Josh.
So I changed the title to make it sound more exciting. So it's great to be here. I will be kind of shifting to talking more science and data. I want to echo what Florian and Patty said. It's it's a great honor to be here. I've really benefited from being part of this community, and I hope that the work that we've done pays forward to the community. ALD, the community that you see here, it seems like it's one room, seems like a small community, but it's really a catalyst. Like if a chemical reaction, you take a small chemical and the effects are multiplied multi-fold. So just some disclosures, we get grants and have done various consulting work.
Sorry, we didn't start with Florian, so I don't know that we've got this working. Let me see. Yeah, there we go. It's this one right here.
So a quick overview. So I'll be talking about what do I mean by big data approaches in ALD. I'll talk about how this data has given us some information on understanding diagnosis in ALD, approaches to understanding cerebral ALD using big data, and finally talking about some of the work in Zebrafish for understanding cerebral ALD. So what do I mean by when I say big data for ALD? So prior to 2015, a big limitation to any work we could do was that ALD coding was not a separate diagnosis with the ICD-9 coding, and so if you're in the hospital as a patient or in a clinic, you are diagnosed with a condition and you get a code attached to being in the hospital or the clinic. And prior to 2015, all leukodystrophies were basically lumped into one big diagnostic code, which meant you couldn't differentiate a patient from a data standpoint who had MLD or ALD or Krabbe disease or anything else. So after 2015, ALD now does have its own code. There are some limitations. There's no code that can differentiate whether someone has ALD or AMN or cerebral ALD, so there's still some problems. Also, we don't really know how accurate the code is, so there are some limitations of the data, but it does mean that starting in 2015, we can at least kind of track patients across institutions across the nation who have ALD. So the system that I've been using for this work is something called the FIS system. It's the Piotrek Health Information System. And it's a large-scale database that was set up by something called the Children's Hospital Association. It was originally established for the purposes of the hospitals helping each other out to try and understand the costs that they had. But what researchers have realized is that this database is so large that we can understand what's going on with patients across institutions. So to give you a sense, so there's about 50 hospitals now that participate in this. They have over 2.2 million patients worth of data in the hospital, millions of inpatient days, billions of dollars of charges, and so you can really track even relatively rare diseases like ALD because you have the power of this system. There are limitations. Not every hospital is in the FIS system. Not every so it's all primarily inpatient, so we can't capture outpatient clinical visits at a pediatrician's office, for example. We don't capture adult data for AMN, but for understanding pediatric ALD, it's a uniquely powerful resource. And so how one concern that we've had is how do we, if we want to help people, we have to make a diagnosis, and so you can't give a treatment if you don't know who the patients are. And so a concern that's been kind of hovering in the back of my mind is that are we accurately diagnosing patients? Are we making diagnoses regardless of what your presentation is? And so I thought, well, let's take a look in the FIS database. We know there should be relatively equal numbers of patients regardless of race. ALD is a genetic disease. It's not, as far as we know, it's not affected by whether you're Hispanic or African American. And so we took a very simple approach. So if approximately 10% of the patients in FIS are African American, then we should see about 10% of the ALD patients should be, with ALD should be African American. And so unfortunately we did not see that. And so So I'll just walk out here to the front. So basically, this is just rates of diagnosis. And so if you're a white patient, your rate of diagnosis is approximately right here, about 12. And this diagnosis rate is basically the number of patients in the FIS database. So this number isn't reflective like nationally. So it's just 12 per 1,000 patients. If you're Hispanic, you can see your rates like half as much. If you're Asian or African American, your rates are half or a third as much. And so this implies that we're missing diagnoses of patients. And so what that looks like is that the rates, if you're black, if you're Asian, if you're Hispanic, are much lower than they should be. So we're missing patients if you're from other ethnic groups. So one concern could be that, is this just what's called a genetic founder effect? Is there some difference in rates of the ABCD1 gene mutation in folks who have Caucasian ancestry or of African ancestry? Maybe we're just seeing like a long term over the course of evolution differences in what mutation rates are in different populations. And so in fact, that's not true. We looked at a database to say, are there different rates of the ABCD1 gene mutation? And in fact, the ABCD1 gene mutation rates are, the number of mutations are higher if you have African ancestry, if you have Asian ancestry. So the answer is not that there's a founder effect, it's that we're missing the diagnosis in patients. So we see this disparity in diagnosis. How about if we look across the nation? Are there disparities depending on where you live, or if you're rich or if you're poor? And so this is not specific for ALD, but we see this across leukodystrophies. And so this just shows rates of being diagnosed with a leukodystrophy. And of course, if you're in a higher population center, you're more likely to be diagnosed just because there's more people living there. But this map does not correlate with population centers. There's certain places where you're much more likely to be diagnosed than not. And so we could see that there's geographic patterns of disparities in diagnosis. And so we kind of dove into this data and we said, okay, can we understand why? What are the factors that lead to not being diagnosed? Why are we failing to make a diagnosis? And so basically, if you're a minority patient, if you're in an area with fewer physicians, those are factors that are going to reduce your diagnosis rate. So this is a little bit complicated, but this is the odds of being diagnosed with a leukodystrophy. And so if you're in an underserved physician area, that's called an HPSA, you're about 3/4 as likely to be diagnosed with a leukodystrophy. Or if you're a minority patient, you're about half as likely to be diagnosed. And so we have problems with diagnosis based on your access to healthcare. How about if you live close to a specialty center? So this is where these are rates of diagnosis based on how close you are to a FIS hospital that has a specialist in leukodystrophies. And so you can see the closer you are to one of these hospitals, the more likely you are to be correctly diagnosed. So maybe not, it's not like surprising as you think through it, but it just shows that if you don't have access to getting to one of these centers, you're not going to be diagnosed. If you're not diagnosed, you're not going to get treated. So there's big problems with how we're taking care of our patients out there. So as we've heard, there's a tremendous opportunity for trying to deliver treatments for across the continuum of ALD. There's great hope for cerebral ALD, but there's a big problem in understanding what the cause of cerebral ALD. So cerebral ALD is very confusing. You can have same members of the family, one of whom can go on and have develop cerebral ALD and have a terrible outcome and even pass away. And a sibling brother can go on and over time just have the progressive AMN form of disease. And as far as we can tell, there doesn't seem to be any differences. Even there's been case reports of twins, so very genetically similar, who have these disparate outcomes. So this is work now that Keith Van Haren's been presenting for multiple years, and he kept talking, and I finally paid attention one time. And so he kept saying these low vitamin D levels are associated with the onset of demyelination. And so I've stolen data from Keith. I don't know if you know this, but so basically Keith is like, okay, and then Keith stole it from Florian, so it's kind of this stealing data from one another. But so Florian's like, okay, there's this process of demyelination, there's this inflammatory component of the cerebral demyelination. And Keith's like, if you think about demyelination, that's something that we heard about for multiple sclerosis, And with multiple sclerosis, there's well-known association with vitamin D levels as a risk factor for something called the relapsing remitting form of multiple sclerosis. So is there something similar going on with cerebral ALD? And so what Keith and his team did is they looked at plasma samples at 2 centers. They looked at a sample of 20 patients from Kennedy Krieger, another 4 patients in Paris, and they looked at the vitamin D levels at those 2 places. And so if you look at the 2 cohorts of patients, they're basically fairly similar. They looked at patients who developed cerebral ALD, and the patients who didn't develop cerebral ALD. They're basically similar ages, similar amount of follow-up, and had similar very long chain fatty acid levels. So basically similar groups of patients. And so it's a small cohort, but that's kind of the data set that Keith had to work with. However, if you looked at the vitamin D levels in the patients who developed cerebral ALD were lower than the group who didn't develop cerebral ALD. So it's very, that's an intriguing possibility. His group did a couple different statistical models to say, like, is this a real association? And basically, the higher your vitamin D level was, through different types of statistical analyses, the less likely you were to develop cerebral ALD. So there are limitations, of course. There's a small sample size, a small number of samples. So finally, I was like, okay, well, Keith keeps talking. I should probably pay attention. So one thing that we've known in the world of multiple sclerosis is that there's this north-south gradient of disease. And so this is just a map of the worldwide distribution of multiple sclerosis. And the closer you live to the equator, the lower the rates of multiple sclerosis are. And then as you move north, those rates increase. And there's now kind of well-known association that there's a vitamin D component. With exposure to sunlight, you need exposure to sunlight to convert your vitamin D to the active form that's biologically active that makes you susceptible or not susceptible to multiple sclerosis. So cerebral ALD has been very confusing, right? We don't understand why twin brothers can have different outcomes. Suggests that there's a non-genetic, at least from a Mendelian standpoint, driving a disease process. So we went into FIZ, into that large database that we've talked about, and said, depending on where you live in the United States, does that affect your rates of cerebral ALD? So this is a map of cerebral ALD. So it's the ratio of cerebral ALD to ALD patients. And so this data is by state. We also looked, we did a multivariate analysis. So we also controlled for how far you were from the hospital, what your race was, whether you were living in an urban or rural location. Maybe there's something environmental about being in a city versus being in the countryside, what your household income was, or what your insurance was. So those other variables did not affect your rates of cerebral ALD. And so this is by state. It's we'll have an updated map soon where we'll have the data by latitude and by zip code, so it'll be much more granular. But it's at least intriguing that there's also kind of the same question of like where you live with an association with developing cerebral ALD risk. So for the last few minutes, I'm going to switch gears here. And this is the part that's why everybody's here, to talk about zebrafish. So this is a picture of an adult zebrafish. And so if you haven't heard, this is my slide to introduce zebrafish. So basically, zebrafish are a small vertebrate animal. They have the same genes we do. They have the same way that they develop their myelin. They grow fast, and they're inexpensive. And so we can do things in zebrafish fast and cheap that you can't do in other model systems. So that's why we're studying ALD in zebrafish. And so I've been told, NIH, for example, says, Josh, zebrafish aren't people. And I'm like, yes, I know. So the point, though, is that you can study stuff fast and cheap, and anything you find, you can then take to a mouse model or to a person model and be like, okay, is this still true? And you can do it much faster, much cheaper. So about 5 years ago now, we developed a zebrafish model of ALD. And so the zebrafish model has the same things that happen in people. They have higher very long chain fatty acid levels. They lose myelin. They have effects on the spinal cord. They also have a motor phenotype. So this is pictures of tracking of zebrafish movement. These little red lines are an automated device that tracks the zebrafish embryos swimming around in a 96-well plate. And the mutants swim less. They have a motor impairment, just like a patient would have problems with movement. And that motor impairment is something that we can then use in large-scale screening. So I'm not going to talk about screening today. I'm going to talk in the last minute here about cerebral ALD. So cerebral ALD, one of the big things has been that it's been hard in a model system in mice or other model systems to model cerebral ALD. There hasn't been a convincing model of cerebral ALD. And so I think that we're hoping that in Zebrafish we're starting to see something that looks like a cerebral ALD model. So this is the motor behavior phenotype. And so on the left side, the black dots are the wild type animals. On the right side are the mutant animals. And so with a inflammatory provoking factor, something called cuprizone plus LPS, we have a inflammatory response in the zebrafish, and the mutant ABCD1 mutants zebrafish develop an inflammatory response and have a enhanced impairment of their swimming behavior. We see this also with the inflammatory markers, something called IL-1B and interleukin, and then also induced nitric oxide synthase. So these are two inflammatory markers. So we're hopeful that this zebrafish model could be something for us to finally be able to study cerebral ALD in an animal model. So just to kind of wrap up here, we've been failing to diagnose ALD patients. Newborn screening is going to be a big step forward for how we do that. There's problems with for minority patients, socioeconomic and geographically disadvantaged patients, and that's something we really need to work on as a field. There's some intriguing data that suggests that cerebral ALD has environmental, perhaps geographic factors affecting its distribution. I think that may give us new insights in understanding its pathophysiology. One, I think, intriguing hope is that the FIS database is really good because we can track patients' healthcare outcomes and understand how they're doing. I think through collaborations with Hunter's Hope and the Lucas Street Care Network, and you'll be hearing from Jackie Wagner tomorrow, that there's power to start to link these databases between newborn screening and health outcomes to really be able to track and understand how people do long term. And I think that's really going to be a powerful tool going forward the next couple of years. And then finally, I'm really excited that we might be able to have an animal model to look at cerebral ALD. I think this may give us some ways to do kind of testing of hypotheses for cerebral ALD. So although I'm standing up here talking to you guys, I've actually leaning on a bunch of people to do work, and so I've had a lot of great collaborators over the time, and many of whom are sitting in this room. And if there's questions at lunchtime, I'd be really happy to talk to anyone who has stuff they want to bring up. So thanks for your attention.